Ευχαριστώ θερμά, αγαπητό Προεδρείο, κύριε Κοτούλα, κύριε Θεοδοσιάδη και οι συνάδελφοι τεχνικοί εξωσωματικής που να τους συγχαρούμε για την προσπάθειά τους για συνεχιζόμενη εκπαίδευση και ευχαριστώ για την τιμητική πρόσκληση. Το θέμα που μου ανατέθηκε έχει να κάνει με την ενδοσκοπική αντιμετώπιση των συγγενών καρδιοπαθειών και θα σας δείξω λίγο κάποια από τα δεδομένα. Η ενδοσκοπική καρδιοχειρουργική σίγουρα δεν είναι κάτι καινούριο. Εάν κάποιος δει ποιες είναι οι βιβλιογραφικές αναφορές τα τελευταία χρόνια, συνεχώς πληθαίνουν. Οι μεμονωμένες αναφορές που αφορούν για την παιδιατρική και ενδοσκοπική καρδιοχειρουργική συγγενών καρδιοπαθειών είναι λίγες και τα επίσημα επιστημονικά δεδομένα όσον αφορά την σύγκριση μεταξύ αυτής της τεχνικής και της συμβατικής δεν υπάρχουν ακόμα. Η φιλοσοφία στην καρδιοχειρουργική, στη χειρουργική, στην παιδοκαρδιοχειρουργική είναι η ελαχιστοποίηση του χειρουργικού τραύματος. Ναι, καλύτερα. Okay. I apologize. Let me just rephrase. The first slides had to do with how many, what are the available scientific data on endoscopic cardiac and endoscopic pediatric and congenital cardiac surgery. Over the course of the past decades, we have been evolving into a less invasive approach, and it's not something new. The first idea came around the mid to late 90s from the Stanford group, and this process has been very, very, very slowly advancing. The idea and the technique has evolved from sternotomy to incisions and then subsequently to ports. And I think that's where we are right now, both in the field of adult and pediatric surgery. The feasibility, the safety, and short-term outcome has been documented in few reports in the literature and is gaining more wide approach. This is a paper from that was published in 2015 and compared two minimal invasive approaches, the totally endoscopic and the right anterolateral, and has proven that they both provide excellent cosmetic and functional results. And that the totally thoracoscopic or endoscopic has much lower incision as well as a much better result and patient satisfaction. The one group from China has even reported back in the almost 12, 13 years ago, something that at that point was almost unheard, thoracoscopic closure of ventricular septal defects. And even their patients did quite well based upon the study that they published, and they concluded that thoracoscopic closure of VSD is feasible and safe. We have embarked into the program of becoming capable in performing endoscopic cardiac surgery by a series of steps that we have followed. We affiliated ourselves with one of the most advanced and older programs performing endoscopic cardiac surgery in adults from Italy. This program provides us with the initial visitation in their hospital so that we can see their setup. And in the following years, they have been proctoring us performing cases on a monthly basis. Initially, we started with acquired cardiac surgery cases, and then as we gained more experience and we became more capable in doing these cases, we proceeded to the endoscopic. Our numbers have been growing steadily. We have experience with over 300 endoscopic cardiac cases. In our initial experience, we had one conversion to sternotomy, 4 deaths all acquired, 1 early reoperation. The older patients we have operated is 93 years old, the younger 5 years old, and the smallest only 12 kilos. The adult cases, the numbers are these. And this is the slide that contains our experience with the congenital cases. In the beginning, we were doing mostly secundus ASDs, but over the course of the years, we have been able to perform even more complex cases. We've done sinus venosus, totally right-sided PVR, subaortic membranes, ostium primum defect, 2 cases of ventricular septal defect, 2 cases of DCRV. We have done 2 pediatric cardiac tumor resections, aortic valve replacement for bicuspid aortic valve, mitral repairs, mitral replacement, and tricuspid. The protocol that we follow is general endotracheal anesthesia, central venous access, peripheral arterial invasive blood pressure monitoring, CNS monitor, NIRS, and EEG monitoring, defibrillator patches on all the patients so that we defibrillate if we need to, regional anesthesia catheter for block so that the patients don't have pain in the postoperative period, fast track extubations. So we have at least 12, maybe more than 12 pediatric patients that have been extubated in the operating room, POC, point of monitoring of the coagulation, and transesophageal echocardiography. Those are the times. For the most part, those procedures are lengthier, and it takes more than to do them compared to the conventional sternotomy. But it pays back when it has to do when you compare it with the outcome, since patients stay less in the intensive care unit and they recover much faster. The need for transfusion is much less. For pediatric patients, we're down to 20-25% transfusion rate, which is much less than you would expect. Complications, of course, we have, and we had. 1 case of reoperation for endocarditis, 1 patient with SVC stenosis after sinus venosus repair that Dr. Jifa was kind enough to fix that for us. Pleural effusion is not an uncommon thing. We had no vascular complications and no death. The surgical technique, we make a transverse incision in the inguinal region and we dissect the vessels, and we use the femoral technique to obtain access in the femoral artery and vein. We inflate the surgical field with carbon dioxide. We use 1 camera port along the anterior axillary line and a second one for a working port. And typically we make a circumareolar incision that aesthetically is afterwards something very, very satisfying. We open the pericardium on the right side, cephalad to the phrenic nerve, about 2 to 3 centimeters, and we put pericardial stitches and we retract them. Since this is organized by the perfusionist, we go into some details as to the systems that we're using. The protocol we use for 10 to 18 kilos is 1/4-inch tubing arterial, 1/4-inch venous. For 18 to 30 kilos, 1/4-inch arterial 3/8 venous. And for the bigger children, 30 to 55, 3/8, 3/8. For the arterial access, anything from 12 to 18 for the artery, and the venous 15 to 23, double stage. And if we need to do something intracardiac, we put another one in the superior vena cava versus the internal jugular. We have the anesthesiologist put a catheter in the beginning, and then we prep in our field, and subsequently we exchange that over wire to another cannula. Usually we put a femoral 14 or 17 in the IJ. The cardioplegia technique we use is the delineator cardioplegia, and we administer that about 30 ml per kilo at 4 degrees Celsius. We cool the patient to 32 degrees, and if it's more demanding procedure, we go even further down, because we believe that part of the myocardial protection is very important. One of the setups you can see here, the cannula in the IJ and the second and the other cannulas in the femoral before we start. For a typical ASD closure, we do it the same way that we do it in open technique, open the right atrium, and if we add a suture, close it or put a patch. We have performed the first endoscopic pediatric case in Greece. This is one of the cases that you have a sizable ASD. This is the image you see on the other side is the vent. The image that we have is very, very anatomic and very clear. This is the postoperative result on a girl that we've performed a quadrilateral sinister repair. You can see the aesthetic result afterwards, so the periorbital incision and the two side ports. Another case with secundum ASD that we use a patch, and this is the immediate postoperative period. When we do the thoracoscopic AVR, this is the incision that we see. We have performed also on some even more complicated cases as we gain more experience. This is a case of a 20-year-old male with a history of infantile coarctation repair via a left thoracotomy, followed by percutaneous balloon angioplasty, then a median sternotomy for arch reconstruction, and then develop a severe MR with a dilated left ventricle and bileaflet prolapse. You can see the mitral valve. And you can see the result afterwards with chordal implantation and ring. This is the left thoracotomy incision that he had in the past. This is the median sternotomy, and this is the third procedure that we've done of thoracoscopic repair via a periareolar incision. The advantages of this technique are as follows: less injury to the patient tissue and anatomy, minimize blood loss and the need for transfusion, almost zero rates of intraoperative or postoperative infections because the incisions are so small, shorter patients stay in the intensive care unit and shorter hospitalization, faster recovery and mobilization. The postoperative pain with the protocol, the anesthesia protocol with our experienced anesthesiologist is of a great value. Very low reoperation rate, and it is very impressive what the patients and the family tell us about the aesthetic result and the psychological result. Usually, typically this technique is a technique that it requires skills both emotionally, psychologically, and technically. You have to be able to, at least in the beginning, be able to identify which patients are best for this technique. The training, there's no doubt that this is a technique that has a steep learning curve. So for sure you need some help and some assistance and some guidance in the beginning, and not only in the beginning. You obviously need specialized equipment and maintenance procedure. There are some disadvantages as the longer time of anesthesia, surgery, cardiopulmonary bypass, and cross-clamp time. It has not been a major problem. The theoretical risk of the small femoral vessels with experience, we haven't had any of those. The cost, for sure, it requires some initial investment as far as getting the right setup, and we need to follow up on this patient so that we can see the long-term outcome. Those are some more cases. I'm not going to bother you. This is a physician ophthalmologist that had a sinus venosus repair with a two-patch technique, and this is the postoperative result on him. This is a patient of Dr. Jifa that I will show you in a moment that would fix a DCRV. And if you could play the video, please. We are on bypass. This is the right atrium that you see. We've put stay stitches on the pericardium, on the inferior aspect, and on the right atrium. We open the right atrium, as you can see, a transverse incision. traction sutures so that we can retract the superior aspect of the right atrium. A lot of suction for the perfusionist. This is the cannula. You can see through the tricuspid valve, the white stuff is the fibrous reaction of the DC RV, double chamber RV. This girl had significant obstruction. The fibrous tissue is the reaction. We put a stitch there so that we can hold it to manipulate. There's a suction in there. We start cutting. This is the muscle bundles that are very hypertrophic, and next to them is the reaction that has occurred from the turbulence and the jet hitting on the endocardium. It's a lot of tissue, obviously, as you can see, since we retract. We start seeing more of the RVOT now. A big piece has been removed. After all this time, and after this part has been cut, then we'll be able to see part of the pulmonary valve. Before it was not visible. More muscle bundles that are cut. You see how bigger the opening is of the RVOT right now. And that's the closure of the right atrium after the completion of the procedure. This is the periareolar incision at the end of the operation. And the two Blake drains that we typically use afterwards in the first follow-up visit. That was the image, and the final one was the last slide that I showed you before. Thank you very much for your attention.
Thank you very much, Mr. Mitropoulos. Does anybody from the audience wants to ask anything? Okay. Do we have Ms. Fanoula Papadopoulou to comment online?
Yeah,
Hi, Fanoula.
I'm here.
Hello.
Hello. Hi, I'm very good. Thank you for having me there. Sorry, I came immediately from theater, so unfortunately I didn't heard the whole presentation of Mr. Mitropoulos, but I saw the nice video at the end, and congratulations. I have a few slides just to, if I don't know if we can share that. Can you see those slides? Can you see it?
Yes, please.
Yes, Fanula, yes, you can see your slide.
Yeah, so people that they don't know me, hi, I'm working currently the last 2 years in Leicester Hospital, which is of course a university hospital, and we are being shared in two places. One is the pediatric, the LRI, and for the 16, 18-year-old congenital patients with acquired, with congenital problems are in Glenfield. So for us, the setting is a little bit different. So the endoscopic camera is in Glenfield, and in small kids, we do have only the minimal approach if we are talking about. Just because it's been a teaching program, just to be sure that we do understand about what we are talking, is more than a decade now. There have been nice papers, and this is one whoever would like to read and see a few things, with a large number of patients of 396 with total endoscopic, but with conventional instruments, and predominantly is ASDs and VSDs. Other with patch or without a patch. And yes, as Mr. Mitropoulos very nicely pointed, that overall the stay and the ICU stay and hospital stay might not be different. The only difference, of course, is a little bit on the timing in theater, but the team needs to be dedicated when we are talking about these patients. So not only the anesthetist and the scrub team, but the wider group also to be supported. So cardiologists to being willing to give the chance in this technique, because it needs to be learned, this technique, and sometimes the numbers are not being there, especially because our interventional cardiologists are taking a lot of the ASD group, so it doesn't stays a lot for someone in, at least with the volume in UK, to learn it quickly. So on that study, the peripheral cannulation was being for the venous 15 to 21 French as an average, and arterial 12 to 17. The weight of the patient was being 15 to 40 kilos, and there was a comparison with the conventional group, which that group, of course, was being much younger. The SVC was being through the third port cannulated with a small incision on mid-axillary line, and they had great results with only 14 of a huge amount of number, as I said, with intracardial residual SUNS, but you didn't have to go back and do anything. And this is also the experience of most centers. Now, this is another study that I want just to mention, because in difference now we are going towards to the right subaxillary ventricular thoracotomy, which we have tried, and it's in adults. I would say it gives a very nice view of the surgical field. And also you don't have the risk of violating the borders of the mammary gland. And this one, again, another study pre-COVID era. I don't know, there is a lot of questions about after COVID, how many centers, and everything comes pretty much from China, but from single surgeon performing all this operation. Again, another retrospective, but this one has a very large amount of patients as a number, 1,672, which now the mean age is 2.3 years of age. We don't have, of course, this kind of experience, and I have borrowed from that paper because nicely they demonstrated how the IVC cannulation to being out of the field, it comes down from the port, and that is the main table that they are sharing, trying to also expand to different type additional procedures. They're saying they have 13 different procedures, including the double commit, it's subarterial we are having experience only on ASDs. So just to summarize and have questions also regarding as a perfusionist, what needs, to think about, what we are thinking as surgeons. So we use end-to-side graft for the peripheral cannulation. And if there have been small, the arteries, they have described that they can have bilaterally. We have never done it. Also, central cannulation in small children, yes, we're doing, and always the IVC is with malleable. Sometimes the jugular vein cannulation is through the field if the anesthetist that we've got is not being trained, and I'm talking again from the adult perspective when we are operating. Any thoughts if it's been better for 2 states and snare? We have never done it. Always we need a vacuum assist for venous drainage. What I want to say is that also now there is the new camera that is a 3D camera, and it's giving a very, very good images with the 3D glasses. It's amazing. It's game changing, I believe. And yes, I just want to highlight that only a fraction of the congenital surgeons, they had the experience and they are performing fully endoscopic, and most of us, we still need mentors to come in theaters. We are having the adult cardiac surgeons with the minimal invasive mitral, and also you need, as I said, very importantly, a supported team. Thank you.
Thank you very much, Fanula. Mr. Kotoulas wants to ask a question.
Yes,
Thank you
please.
very much for coming. Thank you very much for your comment. Just one comment. Why, Fotis, why do you prefer Del Nido and not the custodial as a cardioplegia? Because you have a longer cross-clamp time, so it's more safe to use the custodial one.
We have certainly used the custodial, and it's a very good cardioplegia solution. With what we have found with the Del Nido, obviously gives us 90 minutes, and if it's more than 90 minutes, we repeat. Custodial will give you up to 2 hours and maybe more. With custodial, we have found that you have less of a metabolic effect. We don't have acidosis the same way we have with custodial. The electrolytes are not as high as you have with custodial. And we have, in our personal experience, when we take the clamp off with Del Nido, almost never we have ventricular fibrillation, while with custodial, it's not very uncommon. We've seen that quite a few times with that. So,
just to give an idea, we prefer to give 1 liter of custodial when we are waiting for cross-clamp time about 1 hour, and to repeat the dose. And after when we are ready to remove the cross-clamp, we give blood.
Warm blood to flush it out. Yeah.
To flush everything out.
Yeah, we know that technique too.
So we have no problems. On the other hand, when we used the Nido, we have some problems. And I didn't realize why. Because we had small cross-clamp time and no perioperative problems. That's why we moved to custodial. Thank you. And when we use 1 liter, we don't use any filter. Just 1 liter, and that's it.
Okay. First of all, thank you very much, Fotis, for your presentation. So we can proceed.